of the medical complications of eating disorders are not going to show up in any measurement. And because the nature of these egosyntonic disorders is that the patients will believe they are not sick enough, there's a real risk of going to the medical provider with everyone expressing a lot of concern and coming away with the patient saying, "See, I knew I wasn't sick enough because the doctor just told me there was nothing wrong."
You've arrived at the Mental Health Spotlight podcast with therapist Kais. I have a confession to make. Well, first, I welcome Dr. Gaudiani for coming in here and being part of my conversation today. I'm very excited.
Thank you for having me. It's such a joy to be with you.
Absolutely. I think we're going to cover a lot, and it's going to be a very selfish conversation for me because I feel my clients' voices echoing in my head and their families and all the things that people want to know. So I'm hoping I help to uncover that. But I do have a confession to make. I realized when I sent you some talking points that I didn't mention Gaudiani Clinic and what you do there. So I want to make sure maybe in introducing yourself that you can also tell us a little bit about the great work you're doing in Colorado, correct?
Yeah, I would love to. That's so kind. And full disclosure, I'm at the tail end of a little cold, so I might have a little cough every now and then, and we're just going to go with perfect imperfection on this.
It has been snowing so much here in Cleveland that everyone has a cold. It's like February in Cleveland right now, so I get it.
Yeah, you do. Great. Thank you.
So tell us a little bit about your history medically, what brought you to author Sick Enough, which is what we're talking about. I'll have a great little picture of it on the screen when we do it.
I have an even better picture because it's...
What do you have?
The second edition just came out.
Yours is better than mine.
I'm so proud of it. It just came out like 2 weeks ago, and I'm so thrilled with it. It has so much new stuff. Anyway, we can talk about.
So it's an abridged or an edited version of this one that I'm holding.
It's edition, but it's got almost 50% more material, tons of new stuff, all new medical citations. I'm so excited about it.
But it just came out, right? Like I wouldn't have had access to it.
No. Like just 2 weeks ago. So excited.
Because I'm thinking, did I drop the ball? Because I've been referencing Sick Enough.
No, exactly. And I joke now, like, who even reads that first edition anymore? But the fact is, the new one just came out, and I really am excited. So you can get it on whatever place you like to get books, but enjoy.
And I'll make sure that's in the show notes that folks, especially that do what I do.
Thank you.
Absolutely. So we have a new version of Sick Enough, and you might at some point hopefully have a chance to tell us what's new in that. But let's find out just a little bit about you, because I don't even know. I like to come in here a little clean brain and let you fill me in on how wonderful you are and what you've been doing.
Oh, that's so nice. So I'm an internist who specializes in eating disorders. I've been in the field for 17 years now. And, my story is I'm the oldest of 3 girls. And when I was in med school, my middle sister came to college and had developed an eating disorder. And she's been very gracious about letting the world know that she's my muse. And she was sick for a really long time and never had to step up to a higher level of care. But I've experienced this world as a sister, and I knew nothing about it as she was sick. But I came to understand, because I love her so much, kind of what she was living with. And I held that in my heart. And I had a few other friend experiences that showed me how little medical professionals can listen to those who have complex illness. And in med school, I decided to become an internist, internal medicine doctor. And I thought, I was an English major in college and I love narrative. And so I thought, if I can listen really deeply to patients' stories about themselves and then bring my medical knowledge, maybe we can make a really beautiful, yummy partnership where things can change and where people feel respected, where they feel safe. And so I sort of went into my residency in internal medicine with that in mind and moved to Denver in 2007 with my husband and then toddler daughter, who's now 20, who gave me this cold when she came home from college for Thanksgiving. And
they do.
Love her dearly. It's totally worth the snuggles. And what I started to do was to work at the inner city teaching hospital for the University of Colorado because I speak Spanish and I always trained in that setting. But a year into my employment, the head medical director of the system, who unbeknownst to me was the world expert in the medical complications of eating disorders, said, "Who wants to help me grow and run the world's top medical stabilization unit for critically ill adults with anorexia?" And I was pregnant with my second daughter at the time and a passionate feminist and somebody who really loved developing new things. And I volunteered and I just fell in love with the patients and the whole thing. And I love teaching. So there's wonderful therapists and dietitians in this field. There aren't as many doctors. And so I got a chance to be a teacher in that context and loved that. Helped run that program for 7 or 8 years and then founded my own outpatient medical clinic, the Gaudiani Clinic in Denver in 2016. And the goal was, broadly speaking, to uplift the quality of medical care for people with eating disorders around the world, because I knew that I had this unique knowledge base and that I wouldn't nearly be able to see one-on-one all of the people who could benefit from what I was so fortunate to have learned. And so that was through podcasts and blogs and eventually through the writing of the first edition of Sick Enough. Now, happily, its second edition has just come out. And then it was through clinical care and just showing up every day with a weight-inclusive, fat-positive lens, a lack of fear of complex chronic illness, a complete commitment to a trauma-informed, neurodiversity-informed, loving, safe, equitable medical environment where I could work in a multidisciplinary way with teams and help patients get through the medical barriers that were keeping them stuck in their recovery journeys. And so that leads us right to here.
You don't sound medical at all. You sound like one of us.
Oh, that's the best compliment ever. Thank you.
No offense to our wonderful medical providers, but just hearing you, I thought you ran an eating disorder clinic as the top clinical director of therapy. Like you really get that. And I think that's the confluence that works here, isn't it? The medical with this other piece that's so vital.
Yeah. I mean, I'm so grateful for all of the therapists that I get to work with because I'm not a therapist. I would never pretend to be one. But I do have such a profound love of this patient population. And I do really love bringing stories and metaphor, poems into my sessions and weaving those in with like, okay, here's how we're going to prescribe this medication. And what I think ends up working is that my patients feel cherished. And when I say mine, I have 3 brilliant partners and we all do this work within the same value structure. They feel cherished and seen. I think they feel held up to the best possible version of what they want for themselves. They feel that we're trying to stay really humble and acknowledge when we've made a mistake or have gotten something wrong. And I would say that, my biggest learnings have come in the form of understanding the unmeasurable medical complications that our patients experience, and also the vital, vital importance of recognizing how toxic weight stigma is for people of every body size.
Every body size. I love that you said that. Not too long ago, I interviewed Jillian Lampert over at Emily Program, and she used this great saying of body experience. And it's my new thing now. It's about this whole person with the body just being one little part. So I love that you already spoke to that. Oh, this is going to be so much fun. Okay. Now I got to stay in my lane. It's going to be really hard because I just want to have you all to myself and just.
I mean, you just bring it. You've got amazing questions to ask, but I'm also happy if you ask 0 of them and a bunch of different ones, we're just going to have a chat. We're going to sit here and have a conversation.
I have to stand up so when people listen to this, they can say, oh, I'm so glad that you had that conversation, because not only learning about the clinic, but about what we all need to know more of. I'm going to start with this because I feel like it's on a lot of people's minds. What are like the most important medical questions that we need to think about or be aware of when we're dealing with someone with an eating disorder? So if you're a parent or a loved one or that person, what are the main things that we really need to be asking that maybe aren't being asked?
Yeah, that's a beautiful question. Let's see how I want to answer that. So the first thing to say is that many of the medical complications of eating disorders are not going to show up in any measurement. And because the nature of these egosyntonic disorders is that the patients will believe they are not sick enough, there's a real risk of going to the medical provider with everyone expressing a lot of concern and coming away with the patient saying, see, I knew I wasn't sick enough because the doctor just told me there was nothing wrong.
Amen.
So what it takes is a lot of parental awareness of like what actually goes on in bodies to be able to do some pre-talking. And of course, a great therapist or dietitian can do this with a client as well, to say like, here's what you can expect from a non-specialized outpatient medical setting who are going to do the best they can. They're not going to try to be X, Y, or Z, but they're going to do the best they can. But here's what might come out of this. So what you might say as the parent or the therapist or the dietitian to the client in advance is, The purpose of this medical evaluation is for us to know if there are any measurables, because those are valuable for us to know. And that means in vital signs, in the urinalysis, P-dip, and in blood tests and on an EKG. But also to know that this medical setting may not know how to ask you about the unmeasurables, like your cold hands, your chilly temperature, your hair thinning, your dry skin that doesn't heal as well, your incredible fullness after you eat half of a sandwich, your constipation, your bloating, and your intermittent or absent periods. Or if it's a male patient, they may not know to ask you about sexual function or interest. They may not know how to ask you about bone density risks and athletic injuries. So we're going to say in advance that a standard medical encounter is just to understand what we can rule out as far as measurables. And if you come away with labs, vitals, EKG, and P-dip being fine, that doesn't mean you're fine. I like to tell my patients the house on fire story to help sort of cement this. And the house on fire story goes, let's imagine that there's a young woman standing outside of her burning house, and the fire department comes racing up, and the firefighters come out and say, "We're here to put out your fire." And she goes, "What fire?" And they're like, "Well, your fire. I see the flames. I feel the heat." And she's like, "Oh, no. I would only know I had a house fire if the sidewalk were bubbling. And because my sidewalk's not bubbling, I clearly don't have a house fire." And the firefighters understand she's mentally ill and they go put out her damn fire. And so by contrast, when my patients say, "But Dr. G, my potassium's normal. But Dr. G, my weight isn't as low as it's ever been. But Dr. G, I'm not eating as little as I ever have in my whole life. I must be fine." I'll say, "Oh, honey, house on fire." Because it's not one thing that says you're not doing well. It's the whole set of things. So, when I wrote Sick Enough, and when I talk about this with my patients and their families, I note that each individual human has to develop an understanding of how their body manifests illness. You might have somebody who's in a higher weight body who has a slow pulse at rest that goes much faster when they walk down the street. And that's their only measurable symptom. However, they're also withdrawn, anxious, not sleeping well, cold, not laughing anymore, and they can't concentrate well. And that might have a single medical measurement, but those plus that complex assessment of how much are you able to live in your values versus are you being pulled away from your true values? That's what makes the holistic assessment of illness, and really what helps us guide a need for a higher level of care, et cetera. And I know insurance criteria are so rigid and binary, and they're
I know.
just awful, and they really do so much harm. But when we're talking like face to face about what really comprises a need for a higher level of care, it's not just a given measurement. Some of those can help because we want to make sure we get that in the insurance's face. But the truth is, it's that whole holistic thing, plus the level of the team's comfort with the patient's current behaviors and symptoms. And, if somebody lives in a super rural area and they've got a wonderful virtual therapist and a wonderful virtual dietitian and a primary care doctor who really doesn't know or maybe doesn't care about this stuff, it's going to be a lot lower threshold to be like, "Dude, I'm so sorry. We're going to have to pull you out of life and send you to treatment because this isn't working." And the folks involved don't have the hands-on experience to take care of this. Whereas somebody who has a super, super experienced team and access to all of the medical stuff that they need outpatient, there may be more scope to be like, "Yeah, I would like you to go to higher level of care, but if that's not an option for you right now, we have some wiggle room to keep trying to do things differently."
So the access and the teams that you're exposed to have a lot to do with this. And I know some of that, of course, not only who you meet, but where and how many resources you have, but also the specialties. And you said that in the beginning, that if you go to a non-specialized medical provider, many of which are I mean, they don't get, we get a lot of fellows here. We train a lot of doctors because they don't get this rotation. So we bring them in. Ann Hull, our owner, will bring them in and train them because they don't have it, but they're not everywhere. And the chance of getting one of them is in areas like you mentioned is not as easy. So if you're somewhere, one, try to find a specialist. I guess I'm going to lean into that. Try. But are there other ways to know if the providers will have the kind of informed approach you want? Or like, what do people do? Like, one thing we'll do is we'll give folks what you just said. We'll give them the criteria for a biological assessment for ED. We'll do that. But any ideas on how they can ask the right questions to make sure that person can treat them?
Yeah, there's two ways of thinking about this answer. The first one just acknowledges the incredible vulnerability of a parent or a loved one or a best friend when they're trying to navigate this system. I never want in my answer to imply that if the parent just gets it right, everything's going to be okay, because there's so many uncontrollable barriers when parents are looking for this, from financial to geographical to sort of falseness in marketing, et cetera. And so I want to be very gentle when I suggest, here's how you can do it best, because there's so many things they can't control. By the same token, I would say that directly asking, if you call up a couple of primary care clinic practices, having maybe seen on their website that eating disorders are listed somewhere, and you say, could you please tell me the level of experience of eating disorders of your various staff? There are certain credentials that can help with that, but very few of the doctors and medical providers have them. I think, though, that because the vast majority of medical practices are not going to have eating disorder experience, in part because I've known, for instance, a pediatrician who was passionate about eating disorders, great at them, and she was kicked out of her practice because she was told these patients are too time-consuming, they're too legally challenging, and you're either going to stop seeing them or you have to leave our practice. So, I mean, there's like incredible institutional headwinds against developing this expertise, which is wild. But you can also call a nice medical office and say, hey, who is your most popular nurse practitioner or physician assistant? And could I see a little bit about their bio, or could I have a first visit? All I need is someone who is curious, compassionate, and willing to work together. The truth is that like the actual nitty-gritty of essentials of eating disorder medicine are not wildly complex. It's the human and their heart that matters the most. And if they're like, yeah, you know what? I'm going to read this book Sick Enough, and you're going to send me articles, Mom, and I'm going to be willing to read it, and we're going to muddle through on this together because I love your kid and I want to do this. That's like a great way to do it too.
My gosh. And it so sounds like a couple of experiences I've had with physicians who they didn't know. I did give them your book. I said, okay, start with Sick Enough. Let's start there. And I found that they're sometimes our best champions because the passion that you mentioned is already there. So making sure it's a fit. And unless they're specialized, I'm going to throw that out, because sometimes someone with your kind of training may not feel like the right fit because the young person, at least at the time, may not want to hear what you have to say. I'm going to guess you have to provide some eligibility, some requirements, and some recommendations that are not always desirable by your...
This is true. We are not always the most popular human.
This is for you clients listening.
Yes. But I think even when our clients are pissed off, there's that little bit in the depths of their beautiful hearts that goes, okay, I knew this was true, and it feels terrible and wonderful to hear it. And, I think that also it's not always just like how the diagnosis is made or exactly what treatments are offered. It's the how. So when our patients have sat with us for a 2-hour initial consultation, and we've started by saying, what are your personal goals and values? Because that's what's going to be our North Star. You are going to be the captain of the ship. We want to be the wind in your sails. And then we go through, what are the medical things in your way? And we're able to interpret the physical exam through the lens of eating disorder medicine and really sort of show humor and compassion and interest. And when we say at the end, all right, so you said you want to go back to your soccer season in a couple of months. We're in. Let's talk about what that would take. Just to be super responsive to the human themselves, there's just a little bit more openness to doing terrifying things that otherwise feel impossible.
And you have that authority. I love when I work with a multidisciplinary team and we have the medical team and the doctor or the NP and the dietitian, because I kind of throw you all under the bus. And I say, these are the people that know your physical health and you knowing physical and the mental health. And they're the ones that are going to guide us and give us those recommendations that we need. And I think it's validating to have an authority person that you trust that can say, really, at the end of the day, this is what you have to do. I can't do that, right? Not fully. I can only suggest. You can actually recommend and prescribe. Yeah, it's a good relationship. I assume because you do outpatient, right? Your clinic is mainly outpatient. So you're working with a whole array of people, I would think, for each client, right?
That's exactly right. Yeah, we're telemedicine licensed, I think, in about 47 states. And so we see folks all over the US and therefore have amazing multidisciplinary teams from all over the US. Like, I love the community of brilliant humans whom I just learn from all the time in the form of the therapists and the dietitians. And it's so fun. And so we send each other notes, we email, we can have phone calls, and the patient really ends up like nurtured within this nest of people who are looking out for their best interests.
Yeah, it's a nice wrap service, if you will.
That's it.
Who should be on that team? Who do you think should be having these conversations for a person struggling with this or family?
My feeling is at the very minimum, therapist, dietitian, medical provider. Okay. There's also, of course, scope for a psychiatrist when the patient has more complex psychiatric needs. And yet, I want to be respectful in saying that while having a great eating disorder aware psychiatrist is heavenly to have on a team, psychiatrists in the present moment can be a little bit of an every 15-minute sort of script writer, and they can be a little conservative. So, when I have patients with complex chronic illness compounded by really tricky major depressive disorder, chronic suicidal ideation, PTSD, OT, ADHD. There are times when a standard psychiatrist who's not eating disorder specialized will be like, oh, no, we can't really touch the psychiatric stuff until the eating disorder's better, for instance. And I'm like, oh, well,
we hear that so much.
Disorder isn't going to budge unless we touch the psychiatric stuff. So, I would never try to manage psychiatric stuff outside of my sandbox, like bipolar disorder or schizophrenia. But oftentimes, a really engaged medical provider can also do some of the essentials because we're just going to be not afraid. And we're going to be, I've got so many reps on all of the patients with this that I'm like, well, this isn't a totally standard thing to try, but you've tried all the standard stuff and I don't want you to be stuck anymore and you don't want to be stuck anymore. You want to try this other thing? And that's a really fun dialogue. I think one of my favorite things that I get to do in clinic with my patients is be like, first of all, you're less of a medical mystery than everyone's been telling you. And being a medical mystery sucks because you're going to get extra workup you don't need. You're going to get people shooting from the hip and being like, this is what it is. This will fix you. And it doesn't. And that's frustrating and wounding. But also you end up getting a lot of treatments that hurt you. And so when I'm able to say, you make sense to me, and I have an idea of what we could do next, and I have a lot of hope that you can feel better, that feels like magic.
I'm so stoked because I think like one of the themes here is we're not afraid. There's a lot of people out there that understand what's happening and see it and can treat it and you can recover from it. That's a great message as opposed to you're an anomaly.
Yeah, that's right. You're never too sick for us. That's it. Exactly.
No.
And of course, there are boundaries that we have to draw in the outpatient setting where we're like, hey, things have just gotten past the point that we can treat. And we love you and we believe in you and we can't wait to receive you on the other side of res and PHP. But like, you're going to need to do some more surrounded work so that we can get through these things that you're just struggling to make changes on for a variety of reasons. But there's never a sense of rejection. In fact, we'll sometimes get referrals from patients who are leaving a higher level of care, sometimes sort of not having made the progress they want. And one of my partners will take sign out from the physician at that program who are like, this is a problem patient. They're always complaining about their belly and they say that they have all these food intolerances, but it's not true. They keep asking for a tube, but it's just attention seeking. They've really been disruptive. Good luck. And my partner will see the patient and be like, oh my gosh, this person is so wonderful. They have mast cell activation syndrome. They do genuinely deserve to have a tube right now to bridge until we're on the right medicines to cure and heal their digestive system. And they were never a problem child. They were neurodiverse, and just to be able to see that whole human and reframe.
Just keep getting little chills while we're talking. It's preaching to the choir here. We say here all the time, we say it to our clients, it's on all of our paperwork, medical fragility, because as an outpatient provider like you do, we want to make sure we're not in the wrong lane. And we'll say to clients, so I guess I have two questions here. When someone starts at outpatient, even if they look, unless we know for sure, and we'll screen them, I tell them, let's give this a try. Let's try to keep this teenager at home. Let's do our best. We're going to pull in this whole wrap like you talked about. But I guess I have a twofold question. The one is, how long do we do that? How long do we say, let's play this piece of it? And then how do we know that, what are your markers for? We have to go either to PHP or res or even an inpatient. I gave you a twofold there. Sorry.
No, that's lovely. This is a question that we grapple with all the time in the clinic, in our staffings.
That's why I'm giving it to you.
It's wonderful. Yeah. I mean, I think that all of us who have done this work for a long time, we'd be foolish to suggest there are easy answers to this because there aren't. And we have to keep complex things complex and stay humble. So here are some of the ways that we think through it, even if I don't have specific bright line answers. One is every human, based on their genetic makeup, is going to have a different tolerance for eating disorder behaviors. In the same way that a 90-year-old guy might toast at his birthday, "It was the whiskey," whereas a 30-year-old guy who's been binge drinking for 5 years ends up with liver failure and a liver transplant. This is about different genetic susceptibilities to environmental insults. And so what we know is that some of our patients have a just disproportionate tolerance to restriction or to binging or to purging or to exercise. And they are still sick enough, of course, but their particular bodies just keep on managing. And so in that context, if the patient says, "Dr. G, I know this is going to be a long haul. I've been through a lot. I've got a lot of medical trauma, and I really don't want to go back to a higher level of care. I want to make slow progress." And this is, of course, for the older patient, not for the younger one. And I promise that if I can't make progress, if things continue to decline and everybody's body is eventually going to get dangerously ill, if my blood sugars start to drop, that's probably one of the biggest red flags. I put a lot of patients on continuous glucose monitors now. And they can be really startled to be like, "Holy smokes, I got alarmed 3 times overnight. I would have just slept through those." And that risks brain damage, that risks seizure or death. So that's really that's a bright line. There are certain EKG findings, like a prolonged QTC interval, that's like, nope, your body is no longer tolerating this. There are certain physiologic findings, like your gut just stops working. We have to go a higher level of care then. So there are those. And then we have patients who within the first 4 months of an eating disorder, their body is crumbling. Their heart rate is down, their blood sugar is down, their digestion is awful. And this may not happen at all at an underweight. This may just happen because their body is super sensitive to even those first weeks of undernutrition. And we know that every single eating disorder diagnosis involves a degree of undernutrition. So it's about the unique individual body's response. And both parties will often say, "No fair." The patient has the incredible sort of genetic tolerance to keep on ticking, goes, "I just don't know why my body won't finally say enough is enough, so I feel I can accept the higher level of care I know I need." And then the person who got sick really, really fast is like, "No fair. I've seen people who are thinner, this or thater than me online. Why do I have to go into treatment earlier?" So eating disorders are never fair. And the truth is that you have to learn each individual patient's body and function. And then it's also in the context of what are their resources like. So if I have a patient who has more financial resources, this is part of the tragic, true injustice of how healthcare works, who has really bad vomiting, for instance, I might be able to have them self-pay for a great doctor of physical therapy to do abdominal wall and pelvic floor work so that they don't vomit as much and they can stay outpatient. And if I've got somebody who can't afford that, they may have to go to a higher level of care earlier because they don't have access to that. It involves who's at home with them and how supportive they are. If we have an abusive spouse who's really a jerk and just undermines the patient and constantly tells the patient they're not sick enough, that patient needs to get out of that toxic environment and have an opportunity. But if they've got a super warm, loving, present family, that's going to be a factor in their in the plus category. So there's so many things that go into it. And of course, you want to boil it down to like a tiny little haiku and be like, no, just what is medically unstable? And unfortunately, you got to keep complex things complex.
Yeah. And I like that you said there's a few things that you'll see in the metrics that you'll go, oh no, this is one we know could potentially put your life at risk. But if you don't have those, we're all working as a team and looking at you as a whole person.
And to be fair, if the patient says, oh, look, I don't have those things, but I'm exhausted. I can't keep fighting this outpatient. I need a higher level of care. Or if the family says, Dr. G, we've been doing this for a year. We're tired of the fights at the table. We need respite. That is 100% just as real and appropriate for a higher level of care recommendation as hypoglycemia is.
I love that. And that to me is that brain body connection. Because on this end, we often see that. Clients will tell me, like you hear a lot. I put a little thing in here. I have a client who keeps PR'd in her cross country when her metrics were actually really low. And I just talked to her. I said, what about your brain? What about your headspace, the static, the food noise? I go, how loud is that? And I think almost every single client will admit, even when their body feels okay, that the brain isn't. They're really suffering on such a higher level.
Yeah, that's absolutely right. And that's particularly complex for athletes where strength to weight ratio matters. You know, I see this in cross-country runners, climbers, Nordic skiers, where oftentimes, even for 6 months or so, where their body is deeply in relative energy deficiency of sport, REDS, if we're not getting enough nutrition by accident or in the middle of an eating disorder, they're performing some of the best they ever have. And then coaches and families alike can find themselves in a real ethical bind to be like, well, it looks like this patient is killing it. Why am I going to get in their face? But like fundamentally, I can see they're not doing what they need to do. And the answer is we have to just sit down and have an honest to God talk about it and be like, yeah, how confusing is it that all of your teammates are telling you you've never looked better? Your coach, who might not be aware of this, is saying, oh my gosh, I'm so proud of you. You really got your life in gear and you're really hitting the kind of accomplishments that I always knew you could. But in your head, you're like, wait, all I have is food noise. I am just only focused on what I ate yesterday, what I might eat today, whether that's okay. How am I going to compensate for it? And there's this disconnect that is traumatic. I view it as a trauma because there's an existential threat going on, but you feel powerless to stop it. So in those cases, what I'll say to my patient is, in order to stay in your sport, you have to show me that you can make meaningful incremental progress towards fueling your body again. Because if this goes on, and I don't know what the timeline's going to be, you're going to get injured. You're certainly going to stop performing as well because there's always the other end of the parabola on this. You're going to end up with a more significant psychiatric complication and you're not going to recover. You're not going to train as well. Things are going to fall apart here. I'm not going to say, well, automatically, if you're not eating enough as an athlete, you got to be pulled out of everything. I'm going to give you every opportunity to show me that athletic identity can surface to the top again instead of eating disorder identity, and that you will rest, you will nourish, you will hydrate, you will, as needed, allow your weight to come back up. If you can do that, you are showing me that your athletics really are the driving force here. But if instead what I observe is that fear is driving you, and you say you want to stay in your sport more than anything, but you can't make those changes, then we know we're going to have to make major changes, both not participating in your sport and possibly going to a higher level of care.
And what do you do in those situations? That's beautifully shared, by the way. When a client gets halfway there and they make weight or whatever, they get where we want, but they're still sort of in that orthorexic state where we know the eating disorder is still alive in the brain. Medically, does that get tough because you don't have as much to work with if they're giving you all those points, but yet at the same time, it's still kind of living in them? What do you think about that approach?
Yeah. So that's a beautiful question, and I have a lot of thoughts that come up from it. One is that we as providers have to do our own work so that we're never punishing our patients for the quote unquote sin of suffering from a mental illness. And by that, I mean, I've definitely seen cases where, let's say, a 20-something athlete has, again, they've improved. Their body weight might be reasonable. They might be getting in sort of more or less what they need to nutritionally, but they're very rigid still. They're not able to increase variety. They're overexercising some. And I've seen cases where the team struggles with distress tolerance and is punitive and says, well, you're not going to be able to race because you're not doing X, Y, or Z. And I think that reflects provider lack of distress tolerance. By contrast, in that circumstance, what we do is we say, eating disorders are complex and they can take a long time to get better. We want to celebrate the ways in which this individual has made necessary progress to safety their body. And then we continue to meet and encourage them to identify how are they going to safety their quality of life and their beautiful brain. And we're going to keep saying, is this a plateau you need to stay on right now? Which is vital. You're doing the macros, you're getting in the calories, you're not injured. This is good. This is improvement. When do you think you might want to take the next step? Because you told me when we first met that you actually really love food and you love going out to meals with your partner or your family or your friends. That still hasn't happened. Are you ready to address that yet? Or do you need some more time? Do we need to work some more on your PTSD first? And just have that open dialogue. The more control we can give our patients as far as the pacing and the momentum of their own recoveries, where we set some basic essential standards and then they get to kind of drive the rest, the more I think it ends up really organically settling and being a true healing process that comes from within, instead of fostering that tendency towards wanting the external approbation or affirmation of a loved therapist or dietitian. They're actually doing it from within and healing from the inside.
Which can take time.
A long time. Yeah.
Your fabulous statement of the distress tolerance for us and for families. Sometimes we do the treatment course for the family, I think, more than the person. And so we can all learn to sit in that space and let them take the time. Though we hear sometimes, and some of our medical providers we work with here will say, if it's a young brain, an adolescent, or somewhere in that age, we need to work fast. Because if we work fast when they're that young, for whatever reason, maybe it's the neuro variants in the brain that are able to do it, the neuroplasticity, it's quicker, and it's more linear. What do you think about that? Can we be a bit more aggressive with young people?
Yeah, I think that there's a lot of cases in which that's the case.
Yeah.
If you've had a young person descend pretty swiftly into an ED, the truth is that you may be able to snap them back into their wonderful baseline selves with just nutrition, because we know that brains and bodies get weird when exposed to starvation, and that renourishment is an absolutely vital part of this, regardless of the patient's body weight. And so, yeah, I would say that I'm a little bit more directive and I'm a little bit more linear and a little bit more vigorous when it comes to my younger patients, because you have the opportunity to they've been pushed down, and if you buoy them back up, like, there they are again. Yay, that's so good. By the same token, I think that there are certain precepts in the eating disorder world that are taken as like gold standard and that can sometimes undermine recovery. For instance, every young person who is underweight should be over-restored to give them a cushion. I don't believe that. Because I think that it decreases trust. And the truth is that size stigma is very much alive and well in the world. And that makes young people have a hard time trusting. It doesn't mean that a person should ever be under-restored, but I don't think that by the nature, they should definitely be like, yep, you should definitely be 15 pounds more than your growth curve says you should be. No, I don't think that's right. I also think that this sort of absolutely no sports at all until you are 100% better. No, I think that steals souls as well, because I think anytime we can foster other healthy identities that are non-eating disorder identities, we give the young person an opportunity to become their full selves again. And so to restrict that is to remove an opportunity for them to remember who they fully are. That said, I see a lot of parents who are like, my kid's going to finish this season no matter what, because they have to make states. And I have a patient who is now a therapist and in recovery, who when she was 15, Her father, who was a coach, said, "Your therapist is telling you to go to a higher level of care, but you're going to finish out this season." And my patient remembers demanding to finish out her season, and in her heart was like, "I don't want to finish this season. I know I need help." But her eating disorder was psyched that her dad said, "You finish out this season." And the therapist at the time said, "If you don't get this under control promptly, she's going to be 30 and still struggling." And that's what happened.
What
So
happens?
parents can be like, "Wait, Dr. G, what are you saying?" Like, help them with their other identities, but also hold strict boundaries. The answer is like yes and both. And that's why having at least one member of the treatment team really experienced in eating disorders makes a huge difference.
Because we don't always know. You're saying sometimes we're doing I don't want to do 6-7, but we're kind of doing it, right? We're like, and we don't know. I appreciate what you said because I feel like sometimes most of our work is vetting out the difference between the true identity and the eating disorder identity. And sometimes young people don't know.
Yeah.
And that's really hard. So letting them sample in the space that they think is their identity to see if it feels authentic.
Beautiful. That word simple is awesome.
Now, this makes me think too then about who we are authentically before an eating disorder and GI issues come up all the time. I have clients tell me all the time, no, this is really the way this is. How do we know the difference between GI related to ED and just people who have a lot of GI disruption and intolerance?
The answer is we don't. And so we pay attention to what the patient...
You don't have a black and white answer for me?
Really? Yeah, I know. But what we say is, I'm not going to have a test that proves to me that your belly hurts every time you eat, or that you get nauseated every time you eat, or that you can't poop but every 3 or 4 days. But I'm going to listen to what you're telling me about your body, and we're going to get this barrier out of your way. Because like literally one of the key things that we do in our practice in the Gaudiani clinic is manage complex functional GI stuff. So,
Yes.
I may have a patient who says, yeah, for 5 years before I got an eating disorder, my belly hurt every time I ate. And I just got more and more afraid of food or less interested in it. And I sort of took an ARFID pathway into atypical anorexia, for instance. That's a really common story. And so what we say is almost certainly there's some contribution of your eating disorder to your GI physiology. But then there's the underlying physiology too. So I don't actually care what comes from what. I'm here to help you feel better. So let's work on all of the stuff. I mean, we have so many tools in the toolbox for complex GI. We have really ideal irritable bowel syndrome management. We have, including, gut hypnotherapy via app, not just medications, but like really complex, forward-looking stuff. We have abdominal wall and pelvic floor PT. We have small intestinal bacterial overgrowth treatment. We have advanced ways of managing constipation itself. We have gastroparesis treatment. We have looking at mast cell activation syndrome and all of the ways that affects the GI system. And by the time we've really applied one thing after another, oftentimes patients are like, oh my gosh, I just feel so much better digestively. Then now I can nourish myself more consistently. And then 6 months later, I can nourish myself more consistently. And now I can feel that, my metabolism is faster. So my GI system just is working better in general. And maybe we peel off some of those medicines we needed. But the truth is that it has to come down to what the patient says about their body. I like the model of a migraine to give this example. Doctors so often refuse to believe or take seriously something they can't measure. But when it comes to migraine, there's no blood test or CAT scan that can tell you how bad a migraine is. We have to just listen to the patient's words. And here's where I just am so grateful that I was an English major, because listening to people's words is my whole thing. I specialized in close reading poetry. Just really listening to the nature of the words is what it's all about.
That's the other theme that keeps coming up in here. And you said in that, but let me go back for a second. We're treating what the client needs us to treat. Whether or not the origin of it is coming from one place or another, we'll vet that out. But in the interim, this person needs comfort. You mentioned hypnotherapy, and sometimes with clients who are either medically resistant or we just aren't getting at it, I'm big on try this, go to acupuncture, do this. What do you think about adding in all these alternative options?
Yeah, I think that as long as the financial resources are available for them, where we're not trading off, paying for the electrical bill in order to go to acupuncture. I'm a big fan. I'm about as Western medical trained as exists. And I've had to get really humble in the last 9 years of running this clinic because Western medicine really doesn't capture everything. So I've had to learn about using herbal remedies for small intestinal bacterial overgrowth. I've had to learn about using non-pharmaceutical management of mast cell activation syndrome. I've seen plenty of patients be like, acupuncture is the bomb. I love it. It helps me so much. Massage. So many of our patients are touch starved. And because they have bodies that for one reason or another, don't allow that like human touch that everyone needs. And so with a safe, trusted massage therapist, that can be incredibly healing for people. So I am all about using whatever we have to help. As long as as long as I know enough about it to be like, here's what I think could be the benefits. Here's what I think could be the downsides. Would you like to try this? I recently recommended to a patient, let's get you a red light, near infrared light and see if we can heal some mitochondria through some light turning into energy. Do I have great randomized controlled medical trials on that? I sure don't. But I do have really smart physician colleagues who say, this seems to work for pain and for inflammation and for energy. So if I don't know anything else to do, I'm going to offer alternative strategies.
Another thought I have I want to make sure we capture is different stages of life. So when people are in later stages and maybe been dealing with this their whole life, what is different medically? And then I guess that bumps into looking at what, I don't know if I love the saying, but chronically enduring anorexia or bulimia that doesn't seem to go away. How do you treat those different?
Yeah, so in the last year, first of all, words matter. Obviously, I think this. And I really like the newer usage of long-standing eating disorder as a replacement for severe and enduring. Now, the academics rightly say that gives you a much less specific patient population if you're trying to do studies and you're trying to assess outcomes, et cetera. Fair enough. But nobody ever actually really agreed on what severe and enduring meant.
Even meant.
So I'm not,
It just sounded very negative.
Yeah, exactly. And a lot of my patients would be like, Dr. G, I know I'm enduring, but am I severe? I don't know. How are we defining that? And it went back to that not sick enough thing. So I like long-standing because it just, without judgment, names that this has been going on a long time. And that just feels more neutral to me. I love working with individuals with long-standing EDs because a lot of the times there have been medical things in the way that no one has identified. And those medical things have caused negative conditioning. And so the patient has been afraid to nourish better, to stop certain behaviors. And when we can say, dude, I think we can reduce your suffering medically and give you the opportunity to make different choices, then like whole new worlds get opened up. And so when I'm working with someone with longstanding EDs, it really, with anybody, but particularly with those with longstanding EDs, my question is, what are your barriers? What are your barriers medically? What are your barriers psychiatrically? And a lot of it comes down to undiagnosed ADHD, undertreated OCD, where no one has ever offered them exposure response prevention therapy because they're like, well, there's that anorexia problem. And you're like, dude, we still have to treat the OCD. A lot of them haven't been offered cutting edge, maybe not always FDA approved, but functional treatment of anxiety or of major depressive disorder. And there's a lot of really exciting stuff coming out about PTSD. So I think to myself, when the patient has told me what's in their way, what can I offer them that might ameliorate them? That. And then furthermore, especially if they've had long-standing and they're of an older age, I'll just say, I will do whatever you want in harm reduction. As long as you understand the risks and benefits there to you, I'm not going to be afraid to sit with you in harm reduction. And I'm not going to pull a double cross on you where you sort of get to the minimum weight you thought you could ever bear. And then I'm like, all right, reset the bar. Now we're going to do 10 pounds more. I'm going to say, you tell me if you want to do more. And in the meantime, I'll stand by your side. So that kind of philosophy seems to really support folks with longstanding. And it often occasions more remarkable recoveries than people would have ever expected. But I'm also okay if they stay in a state that they choose for themselves that is bearable within the very unique context of their life experiences.
Yeah, it's again giving them the agency to do that. And again, you not using as much of your Western medical brain and using more of your ICU. Yeah, there's another great example of it. You mentioned too, we have to treat these things. Do you think that's true with trauma too? That because a lot of times people will say you have complicated big T's, little T's. We have to wait for the eating disorder. And I think the newer thinking is we need to at least touch upon it, right?
Yeah, I think that what I've observed about this over time, and I've learned a lot from the brilliant therapists that I've gotten to work with, is that there's a couple of patterns that I see. One is I see somebody who comes out of res and PHP, and they have in the back of their mind this fear that now they have to work through their trauma. And it's so frightening to imagine needing to do that they relapse in order not to have to. So that's one trope. I see a trope also where somebody starts to improve in their ED. And because they no longer have the shell of binging or restricting or purging that's keeping them numb, they start to feel the trauma more and they can't bear it. So they disappear back into their numbness. So in each of these cases, what I like to do is on the medical side, because that's my bailiwick, is to say, how can I ease the way this is showing up in your body? So we might use a low dose of prazosin at bedtime for nightmares from PTSD. Prazosin is just an old alpha blocker that, it might be an alpha agonist, I'm forgetting right now, but it's an old blood pressure medicine. And we discovered in veterans taking it that their military PTSD nightmares went away. So if you can help someone with PTSD go to bed with the conviction that they're not going to be tortured all night long, that's huge because sleep is so huge. Also, a little clonidine patch at a low dose can just keep the mood a little bit softer and a little bit more even. And that can really help so that you don't get those spikes of terror and misery in the middle of the day that undermine your ability to stick with meal plan. And then there's just an incredibly exciting modality that's not new, but it is new to eating disorder and PTSD that I have not published on. Eventually, maybe I will. That's called Stellate Ganglion block. And Stellate is Stellate. So the stellate ganglion is a little group of nerve cells that runs bilaterally on the back of the front of the back of the neck. And it's part of the autonomic nervous system and it talks to the amygdala. And we actually have years of data that if you inject a little bit of numbing medicine into one, and then 2 weeks later, a little bit of numbing medicine into the other using ultrasound, military active service members and veterans have a dramatic decrease in their hyperarousal and in their re-experiencing and in their hypervigilance. So a really brilliant psychologist whom I work with suggested that one of our mutual patients go and get that. She herself was a military veteran and also somebody who experienced profoundly complex mental illness and eating disorder. And it was transformative for her. So now I've probably sent maybe 12 of my patients to good centers for stellate ganglion block. And I would say about 60% of them have said it was transformative. And when
That's huge data.
right? I mean, like when you have folks who have been so halted in their life, in their tracks by PTSD, and 60% of them say, I can take a shower with the curtain closed. I can go out and do a grocery shop and not be terrified. I can take my dog to the dog park and remember that I have a sense of humor. Like this is huge. So, then if you've decreased the physical reactivity, then maybe you can stay on meal while you start to do some EMDR. And suddenly, like the way opens back up. And it's about offering hope, not in a Pollyanna, like sunshine up the ass way, but in a really objective, compassionate, scientific way of being like, there might be a better way to do this. And that really helps people.
I love that you spoke to that. One of my questions, you even knew it, that what's out there that's innovative. And I have heard that from, I think, one of my other podcasts we talk about it. So I'm going to do one just on that now. You've inspired me. But it also shows us something. Eating disorder care is multi-layered. It's intense. You have to be all in. We're not just talking about a prescription and a visit with someone like me. For some people, it might mean all of these other options. But if you get the quality of life and a life you deserve back,
it's everything.
Who wouldn't? It's everything.
That's exactly right. Ketamine's another great option for patients. And I think you know now that intramuscular lower dose ketamine assisted psychotherapy is really the gold standard. And it can just help with neuroplasticity, moving deeper, moving forward in ways that patients have been too stuck to do. So, there's some clamor in the field at times about, we've got to have hope for everybody at all times. Yes, couldn't agree more. But unless we're offering them different tools, then we're telling patients in a sort of scolding way, you have to hold hope, but I'm not going to offer you anything different to help you feel that legitimately. So I get to have this wonderful, deep experience and sort of a lack of fear and a complete joy in being like, all right, what haven't we done? What could be done that's a little bit wacky, but that might make the difference for you? Because I'm not just going to say hope in a vacuum. I'm going to say hope because I'm going to help you feel better. And that's what I love so much.
So exciting. And to your point, there's so many things going on that we're learning that, and some really good efficacy. And the studies are really coming to the surface on a lot of this. So we have options. Last question, at least in this, is just, is there anything we should be doing to help with this medical gap? You open that with what's really important is that we don't have a lot of this learning out there. Are there things changing? Is there anything that we could be aware of or advocate for to get more people like you that know what they're doing medically in this?
Super kind. I think there's a lot of good news. There are med students for weight inclusive care now, which I love. So there's a whole new, and even just that, if doctors showed less weight stigma in the medical setting, that would be immensely important for patients.
Huge.
That's really exciting. I think there's more and more medical providers who are like, yeah, this is an amazing patient population and I would love to help them. And so I do a lot of supervision and teaching and training. And then I think also the dietitians and the therapists who shouldn't have to, but like really absorb this information beautifully. And they are often translators of information to medical providers, sort of on the one-on-one basis. And that really helps too. So I think there's reasons to be hopeful. There's also reasons to identify that we are far from where we need to be.
Yes. So we're not done, but people like you, and we have a lot of pioneers as well that are working on it. In the honor of time, I had two more quick questions, but you've given us a ton of advice. I think there's some really solid stuff here. Is there any one thing that just steps out that you would offer to a family or person starting on a treatment path for eating disorder? What's one really quick thing maybe you want to make sure they hear or do?
Surround yourself by a commitment to self-compassion. When we get hard on ourselves, and ourselves could mean the patient, it could mean their partner, it could mean their parent. When we're hard on ourselves, we're just compounding the injury. We're not being more rigorous. We're not being more hardworking. We're just being mean to ourselves. And so the more we can show ourselves self-compassion and then model that for everybody around us, the better things turn out.
Hard that is for some people. Well, you and I say this, maybe we're in that space, we can do that. It seems like obvious. This is so hard for people to give themselves a break and to be kind and to do the next kind things. I love that you brought that up. I'm giddy over the next question because I've been capturing some of your words and you have some wonderful theme words. What is a word that would describe your journey with what you do and Sick Enough being part of it, this wonderful book?
Man, that's such a good question. This may sound unusual, but the word that comes to mind is love. I love my patients. I love my work. I love sharing what I've learned with other people. I love my team. And I think that when you lead with love, it establishes an environment that is uniquely healing.
Perfect. Yeah. I don't think it was out of the park at all. I think it was perfect. So Dr. Gaudiani, I've so enjoyed talking to you. I was hoping I'd walk away with some new and interesting things for my clients. I've walked away with a lot. And you have come to the table. Wow. Here's some of the points that stand out that you've brought to this conversation: to be humble, curious, human, to look at the whole person, to listen to the words, and to allow for variation. To me, that takes everything you talked about and just puts it in a little. Well,
that's so beautiful. Thank you. That's a wonderful summary.
Well, you brought it. And I love that you're doing practice in this way. Thank you for your time. I appreciate your space.
I appreciate you so much.
Did you get to say what you wanted? Did you feel heard today?
That was fabulous. That was so much fun. I loved it.
Thanks for listening to the Mental Health Spotlight podcast, helping you hold hope on your recovery path.